Thank you to the audience for letting me have the opportunity to speak again at this wonderful meeting. Right, so I would like to talk about strabismus surgery after vitreoretinal surgery, and our colleagues joke that if the patients have double after vitreoretinal surgery, that's a success. But what do we do when they arrive in our clinic in strabismus clinic? So we need to understand that what the VR surgeons have done is to change the eye's anatomy, and they put these bands around the eye behind the recti muscles, and we need to be prepared to take care of this when we go in and do surgery. And sometimes the band is so tight the eye is completely changed after the surgery. So we face many factors trying to deal with these patients. We have mechanical factors, the muscles are changed, how to do local anesthesia in these cases, and sensory alteration may be a problem as well. So what options do we have? We could occlude the eye, we could use prisms, botulinum toxin, or surgery. And we tried to look at this in our clinic in Copenhagen a few years ago and found 13 patients we wanted to help. And all of them had quite nice vision, and 3 of the patients had torsional diplopia, all kinds of deviations. So we tried to look at how can we help them, and 5 of them were happy with just prisms, but 8 went on to have strabismus surgery performed. And before we do these cases, we try to be prepared. We put all the information on the board in the operation room so we know exactly what to expect when we go in. We do the force duction test under general anesthesia. We press the eye into the orbit to test the superior obliques, and we leave the eye up in the normal position to test the recti muscles before surgery. We put the numbers on the board so we know exactly how tight was this eye, which direction could it not move. We put that on so we are prepared. We put the plan on the board, and we draw where are we going so everybody in the room knows what the plan is. And this nurse will help us during the surgery. So look at the cases. We did 8 patients. 1 of them had a Faden operation on the other eye, and we removed the buckle or band in 3 patients, and 2 of the patients needed 2 extra surgeries. So in general, the results were good. Torsion resolved to under 2 degrees in all patients, and no of the patients had redetachment, which of course was a fear as well. Sometimes these silicone bands might extrude and we need to take them away, but do we need to remove them when we do the strabismus surgery? Well, there is a group in the US and Denmark who looked at historical data to try to answer this question, and they found that in patients with, if you remove buccal in this surgery group, it does not improve the strabismus outcome. Another thing we need to be aware of is you have a buccal for many years, the sclera can be very, very thin. So if you want to work on these patients, you need to see what you're doing, because you can perforate the sclera just with a scleral hook. Silicone oil is another unfriend during these surgeries. They can produce fibrosis and cysts. And adjustable sutures may help you reach the goal and do what you want to do. And the problem after you do the first, if you do this, the eye with the retinal detachment first, the problem is that the eye with the buccal has a lot of scarring and can be very stiff. So the patient may have incompetence and diplopia. And can we improve this? So this is a figure of how the green single island of binocular visual field is where the patient works. Faden sutures may be difficult to perform, and there is a risk of perforation if you do this to the sound eye of the patients, and not all the patients want us to touch the good eye. Another way to solve this is to use a Y-split technique, which does the same as a Faden suture, but is much safer. And this was described by the group in Austria 20 years ago. And the principle is that by splitting the muscle and suturing to the side of the insertion, you actually reduce the torque. So the lever arm is shorter and the torque in that direction of pull is less. So let's see if we have a scleral buckle of the left eye, and this patient looks to the right. The eye does not move so much, so you have they will have double at right gaze. So can we help this in a way? Well, what we can do is to put a Y-split on the sound eye on the lateral rectus, and what happens then is that you slow the lateral rectus down, and you actually keep the patient's the adductions are balanced at that side. So here's a case where we did this on a sound eye. He had a routine plaque in the right eye and had big. So yes, so he had a double at up gaze, and we put a Y-split on the good eye and the super rectus and recessed this a little bit as well. And that way you can balance the adductions in up gaze in his case, and his diplopia was gone. So if you do the Y-split only, it will not change anything in primary, but you can have effect in the gaze where the muscle is pulling. And if you combine it with the recession, you can add to that in primary. So Y-split is a safe and predictable alternative to Faden sutures in incompetence strabismus, and especially in cases where you want to not harm the sound eye, the good eye, we can do this in the good eye in retinal detachment patients. So in patients who had strabismus surgery, who had VR, retinal detachment surgery done before, diplopia in primary and side gaze and up and down, they can have all kinds of problems. We can treat this with prisms, but if there's, often if there's torsional diplopia, we need to take care of this with surgery. The scarring is a challenge. There's a risk of perforation of the eye, and we always use a microscope to be sure we have the detail we need. And if the silicone buckle is protruding, we remove it, but usually we leave it in place. And in these patients, we want to help them with different strategies, orthoptic surgical treatments, and we may reduce diplopia, correct their abnormal head posture, increase field of single binocular vision by working on the other eye, and also improve psychosocial aspects. And if it's torsional diplopia, we know we need surgery. If it's only horizontal or vertical, they may be happy just with prisms alone. So surgical strategy is to work on the detachment eye first. You may remove the buckle, but it does not necessarily help you. And if incompetence and diplopia, we offer Y-split sutures on the sound eye to slow that eye down, to increase the field of single binocular vision. Thank you.
Thank you, John, for that illustrative and very animated talk. It's